Right, now we're on to hear about your decision, really, when you manage patients. Now, I don't want this to seem too like a lecture, but what I'm trying to give you is the structure of the way I would think about it, and most of what I talk about here will be concerned with the management of malignancy. And I choose that subject, and I'm going to talk about malignancies in the head and neck, because that's my field, because the principles of managing malignancy, especially the surgical ones, I think are the same across all the disciplines. So that's why I picked that. So your first question in this is the approach medical or surgical? And I can't go into that in great detail for the moment. Now that is Hippocrates, and this was one of his aphorisms: those diseases which medicines cannot cure, the knife will. Now that's a tricky one, and I wouldn't want you to feel like that, really. It's another one of these ones where doctors think, well, medicine's not working, let's do an operation, it will. So that one is a caveat, watch out for that one. But that's what he said, and he was referring actually to a very specific area of disease in which that's probably generally true. Right, now, in the management of malignancy, you know what you've got there, others have talked to you. So if I talk very broadly, and leaving aside some of the more advanced approaches here, when you have a cancer, or you're dealing with a cancer, what are your options? Well, first, there is surgery, which is what we're primarily thinking about here. There is also radiotherapy, there is chemotherapy, and who knows, there might be some much better measures coming up in due course. And they all will sometimes work on their own, but most usually, as you will have experienced, they are complementary. They complement one another's action. And working out what order you do things in and how much you do is very much a team effort, as you will have seen, between the oncologist and the operative surgeon. So the options of those, and I think what you're doing when you see someone presenting with a cancer initially is weighing it up. Obviously you examine it, you scan it, you do all sorts of tests, you see what the extent of it is, has it metastasized, etc., etc. And then you really have to make a strike as to whether your approach is going to be primarily palliative, which is as useful a role as any, so there's not any question of that being a second-hand sort of approach, or is this a curative bent? Now, one of the problems with that is that they, unfortunately, swap around. But if I can just go back to that in half a second, this is what I think are the three questions which you should be asking yourself when you have made the decision that you are going to operate. First of all, can I remove this? Now, there's some pros and cons about that, and there are some limits on that, and I'll talk about that in half a minute. Can I remove it really in its entirety, in a nutshell? There's no point in taking part of it out. And then there is basic concern, of course, if there are metastases, it's very often not the case that dealing with the primary without dealing with them is a good idea, but sometimes it is. There are some tumours where you might do that. So number one, you assess it, you look at it, can I remove this? The second thing is that your removal might be pretty drastic. It might be minimal, in fact, but it could be pretty drastic. And the next thing you should ask yourself, what price is the patient going to pay if I set out to achieve my aim, which is removing it? And then the third question is, yes, I recognise they're going to pay a price, but I think it worth it, and the patient thinks it worth it. And so, having done that, how can I put I stroke we, because you've often got a team here, you will have various nursing helps, other colleagues and so on. But your question is, how can I make it good? Can I remove it? What price do they pay? And this may be functional, or it may be cosmetic, or it might be a bit of both. And you'll see some examples, which I'll give you in a minute, which are both functional and cosmetic, and have been dealt with in various ways. Now the problem with cancer is that you might start off on a curative tack, and of course only too often you have to change to a palliative tack. I should have dotted that one because very occasionally, certainly in my field, you might see the most astonishing result from approach which was perhaps palliative, and I made a decision, say, not to remove the tumour, but with the radiotherapist, the oncologist, we thought that really a course of radiotherapy might well help in a palliative sense. And surprise, surprise, there's a fantastically good response. Now, you've got to be careful if you move in surgically with that one, but you sometimes see that line moving. That should certainly be in a thick, broad one, but this should be a little dotted mill there. Now, there's one really tricky area that you are going to find yourself in. I'm not sure whether I put this slide. It comes in a minute or so. There's this rather difficult situation. Of course, you think of palliative as avoiding, if you might say, a sort of surgical interference. And obviously it's about the well-being of the patient and the quality of their life until you know that this disease is inexorably, you think, going to take them away, carry them off. But you might think of undertaking radical palliative surgery. Now, I'll show you an example of that in half a second. This is a big operation. Now, one of my colleagues, who is still with us really, but I haven't seen him a long time, is a blunt Yorkshireman and a very good surgeon indeed, worked here with me. And he used to call it controlling the manner of their dying. Sounds harsh to put it like that, but he was prepared to do pretty radical surgery in order to make the death of the patient or the dying process that much more acceptable. Show you the sort of thing which I would put in there in terms of radical palliative in half a minute. Now let's just have a look at this question, can I remove it? Because there's a sub two bits to that. Can I remove this tumour? And there are limits. They might be relative. In other words, in removing this tumour, I'm going to remove something which is going to need being replaced, which is the next step, of course. How can I make it good? But you might decide you cannot possibly remove this tumour, because removing it is going to inevitably, when you're seeking for a decent margin around your tumour, removing it is inevitably going to be incompatible with living. Now, a good example in my territory would be a tumour at the base of the skull, a malignancy here, where I might perhaps have had to been able to get round it and remove it, but in order to do it, I would have had to take the internal carotid. Now that would cause an almost fatal incident in the operating theatre, if not later. So you first of all say, I've got to have an adequate margin around this tumour, and if I do that, have I got an absolute limit, or can we get round this? Now actually, that example I've just given you, a lateral thinking surgeon or not might start doing something else. And if you, for example, are going to take the internal carotid out on this side, if you gradually obstruct it, the other one will increasingly take over the function. It's a high-risk strategy. It's done in America a bit, but that would be one way of sort of getting around it, if you want. But to me, that would be an absolute one, with the evidence I would have from other people's series, and of course your own ability. That actually should be a golden rule. Know your own limits should actually have been at the start. That's perhaps the most important. Right, now this is actually what I'm going to talk about a bit in a minute in more detail. This is the end result of a total laryngectomy. So you can see what we're looking at here. We're looking into the back of the larynx. The larynx has been opened, and that rather nondescript, apparently sort of looks little more than a sore, is actually a cancer of the larynx. And this mass here are the lymph nodes which drain that portion of the larynx, and that's full of malignant tumour. So that is an adequate excision, you hope, but you will have obviously scanned and looked at all the other lymph nodes around. This is a tumour that spreads by lymph nodes.